So my session is Updates in Surgical Oncology, and I was asked to speak on 3 different topics within surgical oncology. The first topic I was asked to speak about was robotic surgery and nursing implications for robotic surgery. The second topic I was asked to speak on was enhanced recovery after surgery, which was actually, ERAS was developed in Europe and then came over to the States. And I also spoke on HIPEC, which is heated intraperitoneal chemotherapy, which is infused after the tumor debulking or cytoreduction into the abdomen to kill any gross cancer cells. The HIPEC procedure is basically hooking the abdomen up to a machine in the operating room, which is most commonly similar to like an open heart bypass machine. When somebody's having open heart surgery, they kind of go on to that bypass machine so that they can do surgery on the different vessels. And so this is the same concept, is that the abdomen is open and there are tubes that are inserted into the abdomen, and the abdomen is first cleansed with saline, and then after that runs through for about half an hour, then actually the chemotherapy is infused for another half hour, and then the saline is re-infused to kind of remove all of the chemotherapy. And it all filters through this machine that's heated to 42 centigrade. And the whole concept behind that is that heating the chemotherapy actually enhances death of the cancer cell. The benefits to robotic surgery are really a shorter length of stay for the patient. The patient doesn't have the large incisions that they get with traditional surgery. They're very small sites that are basically like puncture wound sites that allow the camera within the abdomen, as well as 3 arms that can perform the surgical procedure. So the patient therefore doesn't have all the incisional pain that accompanies an open procedure. It is very beneficial for the surgeon in that it magnifies the field about 10 to 12 times what the normal seeing eye can see. And with those robotic arms, they're able to get into smaller spaces within the pelvis as well as in the head and neck to be able to operate where sometimes they wouldn't be able to do that with just their own instruments and hands. So the big emphasis, I think, for oncology nurses is education. Because these procedures are not the classic open procedure, the robotic procedure has the smaller puncture sites for the arms and the camera. The patients don't understand that they need to get up and get out of bed. The day of surgery, we actually get our patients up into the chair, and then we expect them to ambulate post-op day 1. We do have early feeding for these patients with the robotic cases, so they're usually given like sips of ice and water, and then they're advanced to a clear liquid diet the next day. And sometimes families, not understanding that, kind of try to derail the nursing staff who are trying to actually take the best care of the patient that they can take. So we really emphasize education before surgery, and then certainly after surgery, we try to re-emphasize what they were taught initially. So I think the robot is a very expensive piece of machinery. And so you're going to see those in your larger academic centers. A smaller hospital may not have the funding to be able to purchase the robot, so that certainly would impede somebody in a smaller community setting to be able to have robotic surgery. So the cost is a huge factor in being able to even offer a robotic program. The other issue is that there is a a skill level that needs to be developed. Surgeons initially were trained with open procedures, and then when laparoscopic surgery became available in the 1990s, they were also trained on that. This is a whole new training for them, and the learning curve, the literature is reporting to be about 60 to 80 surgeries before a surgeon is really comfortable and competent doing that procedure. I see more cases of areas of solid tumors that we have not utilized robotic surgery yet in. I see other things being developed in a way that robotic surgery can be utilized. But I think we've been utilizing it in the US since the late 2000s, and so even though we have experience in some areas, I certainly think there's room for growth with that. I think that it's still a developing field, and I think that, like I said earlier, I think finances will play a lot into being able to offer it to more patients. We all live in countries that have large urban areas and then smaller rural areas that I just think may not over time even be able to offer robotic surgery to patients. And like I said, I think it's an evolving field, so I think we really are collecting data right now on things, and we may find other areas of improvement. I think the take-home message for nurses who attend the session is really education is a primary piece of taking care of all of these patients. Patients need to be educated on the robotic piece of it and the earlier return to mobilization and eating, as well as the ERAS protocols also emphasize that also. And then with the cytoreduction and the HIPEC, I think nurses need to really use their assessment skills and to be able to monitor vital signs. The patients that undergo cytoreduction and HIPEC have a lot of fluid shifts within the abdomen itself that come out of the vascular system. And so we're always concerned about replacing those fluids so that we keep our kidneys perfused well. And so I think that there are also a lot of complications that can go along with the cytoreduction and HIPEC, so that they need to really report things that they know are unusual in the post-op course.